This talk has been designed just not a viewpoint of talk, but just to rebrush or refurbish our concepts of heart failure in general with reduced ejection fraction as well as preserved ejection fraction. What are the sad truths about heart failure in general? The sad truths are heart failure has higher mortality at 5 years than many dreaded cancers, including leukemia, colonic cancer, and even non-Hodgkin lymphoma. Heart failure is a progressive condition, and every hospitalization increases mortality on the right axis and decreases the quality of life on the y-axis. If you look at the median survival after first hospitalization in heart failure, it is around 3.7 years. And after third hospitalization, it is barely 1.3 years. 9 out of 10 patients with heart failure with reduced ejection fraction remain symptomatic despite maximally tolerated guideline recommended therapy. Are Indian patients different? Yes, Indian patients are younger by at least 20 years as compared to their Western counterparts. Indian patients have 10-fold more mortality when they are admitted with acute decompensated heart failure, and post-discharge, they have got 3-fold more mortality. If you look at the inter-CHF study, this showed 23% of Indian heart failure patients are dead. Mind you, dead within 1 year of diagnosis. And why is this so? Dr. Jabir is here, I will show you some of his data as well. The prevalence of heart failure in India is around 10 million patients with 1% adult population affected with heart failure, more younger patients, poor guideline directed medical therapy adherence of close to around 25%, which is miserable, and incidence of diabetes 50%, incidence of hypertension 40%. This is the famous Kerala heart failure registry or Trivandrum heart failure registry. Dr. Tiny Nair is here, Dr. Jabir is here. And this registry showed us that 3 out of 5 patients of Indian heart failure with reduced ejection fraction die within 3 years. So the 3-year mortality is 60%. Lack of guideline directed medical therapy is a problem, a big problem. Adherence to therapy is poor. And we, together, with the help of pharmas, must do something to improve this adherence. What are our goals in heart failure? Increase survival, 2, reduce hospital admissions, and 3, improve quality of life. These are the 3 goals of heart failure. Well, how was our journey so far? I must say, the journey was very exhilarating and exciting, starting from the consensus trial way back in 1987, all the way to CBIS 2, CBIS 3, Merit Heart Failure, Copernicus in year 2000, and then the recent most emphasis in 2011 with eplerenone. All these trials pivoted the way of 3 first pillars of HFrEF therapy: RAS blockers, beta blockers, mineralocorticoid receptor antagonists. But mind you, ACE inhibitors do not reduce the risk of sudden cardiac death in HFrEF patients. And then came a big step forward. This big step forward with small feats of ours was the Paradigm HF. The Paradigm HF was a trial which enrolled patients with HFrEF, ejection fraction less than 40, NYHA class 2 to 4 with elevated NT-proBNP to ARNI versus enalapril. Mind you, this was the largest mortality morbidity trial of HFrEF ever since the SAVE, since the consensus. And it was the most geographically and racially diverse trial with representation of Asian population of 17%. Having said that, what were the results? 20% across the board reduction in cardiovascular death, heart failure hospitalization, and sudden death as well. I repeat this sudden death issue because this is the game clincher for this molecule. Number 2, 16% reduction in all-cause mortality despite whatever side effects you name of, hypotension, hyperkalemia, reduction in EGFR, and so on. Number needed to treat with ARNI are 32 for 36 months to prevent one death. Mind you, these numbers look lesser for those numbers needed to treat comparing with ACE inhibitor, beta blocker, or MRAs. But mind you, ARNI reduce death, reduce hospitalization on the top of the background therapy with beta blockers, RAS blockers, and MRAs. When trials like FSS, RALS, etc. were conducted, people enrolled were in miserable background therapy, 17% on beta blockers, 30% on MRAs, and so on. So it is very important to note that ARNI has succeeded over optimal background medical therapy with 95% on ACE inhibitors, 70% on beta blockers, and close to 67% on mineralocorticoid receptor antagonists. Well, what about quality of life? That improved in as early as 30 days. NYHA classes improved and quality of life by the Kansas Quality Questionnaire improved in this group of patients. The benefits, of course, interestingly, were preserved irrespective of age, ejection fraction quartiles, EGFR quartiles, systolic blood pressure quartiles, and NT-proBNP tertiles. So irrespective of what was your baseline independent NT-proBNP, irrespective of what were your baseline in NYHA class, the benefits remain. And all the Asian ethnicities, all Asia, East Asia, South Asia, Southeast Asia, they all benefited. %20 of stable patients in Paradigm had an event. 50% of the time this event was death, and 60% of these deaths were sudden cardiac deaths. So even in a carefully conducted, well-controlled, well-monitored, randomized trials like Paradigm, if 20% stable patients have events, we should wait? Certainly not. So ARNI should be started, in my opinion, as early as possible in every single patient with stable HFrEF who is on ACE inhibitor, if cost is not a constraint and if potassium and EGFR is not an issue. Therefore, 2022 guidelines released just 20 days ago show class 1A recommendation to ARNI. It has moved one class up from class 1B to class 1A. Is acute decompensated heart failure any different than de novo? Certainly. Acute decompensated heart failure means a patient who is known of heart failure gets admitted breathless, hypotensive, or ill in an ICU. De novo heart failure is a patient who was not known to have heart failure before, gets admitted in a bad shape. What is the difference? The difference is de novo heart failure patients have lesser comorbidities, more precipitating factors like arrhythmias, infection, valvular incompetence, or cardiac ischemia. So they are more modifiable risk factors at the backdrop as compared to acute decompensated chronic heart failure. And on the top of all that, the de novo heart failure responds to ARNI far much better than patients with acute decompensated heart failure who are chronic. So the Pioneer heart failure study was designed just to address this issue. It enrolled patients with acute decompensated heart failure who are off inotropes and off vasodilators for 24 hours. Randomized to ARNI versus enalapril. Well, what happened? What happened was the ARNI arm showed faster and greater reduction in NT-proBNP. It showed 42% risk reduction in the primary composite endpoint of heart failure hospitalization and cardiovascular death in as early as 8 weeks. Which other therapy gives benefit so early? Hardly we know of, other than probably SGLT2 inhibitors. And on the top of that, the benefits were consistent in de novo heart failure, in acute decompensated heart failure, and whether the patients were on pre-ARNI, on ACE inhibitors, or were not on ACE inhibitors. The benefits were the same. And one more truth emerged. The subgroup analysis of this study, in those patients without prior ACE exposure, benefited even more and even earlier. So patients who were on ACE inhibitor, when were shifted to ARNI, the benefit started at 14 days. But those who were not on ACE inhibitor and given ARNI de novo, naive, the benefit started as early as the 4th day of therapy. That is, we have a couple of trials. De novo heart failure is a problem worldwide. 40% of patients in report HF registry and the prevent registry have de novo heart failure. And the pioneer subgroup analysis has shown that in de novo heart failure, mortality reduction is even more impressive as compared to chronic HFrEF patients who get decompensated. So de novo heart failure benefits earlier and magnitude-wise more with ARNI therapy. Transition study was done exactly to address this issue, whether de novo heart failure patients will benefit with ARNI. This trial was done for de novo heart failure patients. The subgroup analysis shows this slide that adverse ventricular remodeling, which Dr. Chopla was alluding to so vividly in his inauguratory talk, reduction in left ventricular dimensions, reduction in left atrial dimensions, improvement in ejection fraction with ARNI was far superior than with enalapril. Reduction in troponin T concentrations, which is the marker and the hallmark of myocardial injury in HFrEF. As many as 12% patients with HFrEF, when they are admitted sick, have elevated HS troponin. They don't have myocardial infarction. They have myocardial injury. The injury is reversed with ARNI. And what is more de novo than prior heart failure patients achieved the target doses of ARNI in no time. So my question to myself and to all of you is, should we wait till a decompensation happens? Certainly not. Should we wait for the first follow-up? Not really. The moment the patient is little stable, out of the ICU, about to be discharged 3 days down the line, start ARNI. Because that time the patient's mind is vulnerable and he will stick to the ARNI therapy for longer time than when the ARNI started in the OPD in your consulting room. Transition study therefore concluded that de novo heart failure patients must be started ARNI to prevent disease progression. 2021 ACC update says the same. It says because of new evidence, ARNI is now recommended in newly diagnosed ACE-ARB naive patients upfront, not those who tolerate ACE inhibitors. The ESC 2021 guidelines endorse the same viewpoint. And of course, the HFrEF management 2022 reaffirms the role of ARNI as class 1A indication. It has moved up a notch from class 1B to class 1. How do you manipulate the dose? The guidelines say, but this is open to all of you all experts, if the dose of ARNI is less than 10 milligram, enalapril is less than 10 milligram, dose of ramipril is less than 5 milligram, the ARNI dose should be 50 BID. when the dose of enalapril is more than 10, the dose of ramipril is more than 5, the dose of ARNI should be 100 BID. But we will be discussing. Ask me this, Dr. Ponde, I am in a small dose, 50 milligram half BD, and then you could make it only 50 milligram BD. But my daughter read the trial and she said 200 BD only benefits. Not really. Despite whatever dose you use, 50 BD, orange, 100 BD, red, 200 BD, yellow, hazard curves, all the doses give, if not equal, near equal benefit. Now that is something strange and remarkable with this. That irrespective of the systolic blood pressure, whether systolic is less than 110, 110 to 20 or less than 100, the benefit of risk reduction is at least 12%. At least 12%. Going ahead, very interestingly, in the paradigm trial, patients on enalapril who developed hypotension did much worse as compared to people with ARNI who develop hypotension. Well, what is the difference? The difference is, despite hypotension, ARNI preserves coronary perfusion. And this has been shown not in one, not in two, 3 big time studies. One by Javed Butler, second by Scott Solomon, and third by my good friend Caroline Lam from Singapore. So what we need to remember, that hypotension with ARNI is different than hypotension with ACE inhibitors. I will say only one thing: manage your volume, reduce your diuretics, reduce the loop diuretics, increase the liquid intake, reduce the dose of ARNI temporarily, and you will get rid of the hypotension. 2 weeks later, when the BP is better, up titrate again. Not a big issue at all. Well, this Egyptian journal article shows clearly a light on this issue, and it has now transpired into guidelines. What do guidelines say? The ICD is recommended for the HFrEF patients only when, after minimum 3 months of therapy inclusive of ARNI, ejection fraction remains less than 35%. In my personal, very small clinical experience, I have a data. If time permits, at the end of the session, I can show on my laptop close to around 600 patients so far. The mean increase in ejection fraction is 7%. Mean increase. The highest was 15% and the lowest was around 5%. So this drug may obviate the need for implantation of ICD. This is a gap in evidence. Dr. Chopra showed me this slide the other day, that there is no data on significant positive effects of CRT or ICD when the patient is on 4-pillar therapy, including ARNI. What does this mean? Are we going away from devices? Not really. We may be going little away or closer to ARNI. In Kerala registry, 50% patients had diabetes. 50. In my personal experience, the figure is close to around 20 to 30%. But what is important is, in the pivotal trials of HFrEF, 30% patients had diabetes, type 2, and 5% patients had type 1 diabetes. ARNI benefited irrespective of glycemic status. ARNI reduced HbA1c by 0.7 gram over and above enalapril. In fact, there is a beautiful case report with ARNI in a patient on insulin with HFrEF leading to hypoglycemia. So ARNI is a powerful molecule to reduce HbA1c, and need for insulin is reduced by 30%. Remember, need for insulin is a bad news for a heart failure patient, because the moment somebody tells me insulin, I think of weight gain. Weight gain is bad for heart failure patients. So if any molecule can prevent my patient of failure needing insulin, well, I will appreciate that. I will welcome. HFpEF is a different animal, different ball game, different war zone. In one single sentence, I would say HFrEF starts at heart and then it goes everywhere else, whereas HFpEF starts in all other systems and then goes to the heart. So it's a multi-system disease, and therefore all the previous trials, I preserve with irbesartan, PEP with perindopril, CHARM with candesartan, and TopCat with spironolactone, they failed to show mortality benefit in HFpEF. Why? Because 50% of mortality in HFpEF is non-cardiac mortality. Going ahead, the mortality curves of HFpEF and HFrEF are nearly the same. They don't differ. Therefore, Paramount trial showed us with ARNI that ARNI reduced NT-proBNP, reduced left atrial size, and improved quality of life. This was a small trial, what we call a friendship argument with the molecule, with HFpEF. It gave an inspiration to design the Paragon. Unfortunately, the trial did not show reduction in mortality, but it showed 15 to 18% reduction in heart failure hospitalizations. Interestingly, there was a gender heterogeneity. I don't understand why in the entire life the gender heterogeneity is there, even at my own home. So females tended to benefit more than men. And out of the ejection fraction quartiles, people up to the ejection fraction of 57% benefited. 57% in men and 60% in women. So if you combine Paragon and Paradigm together, right from ejection fraction of 25 to 60, you have benefit of this molecule. I sometimes wonder whether this is too good to believe. Isn't it too good to believe? The guidelines have given ARNI a class 2B recommendation for HFpEF, and FDA has given it clearance to start ARNI for Not go into details, but hyperkalemia, which is a nagging problem, patiromer will be with us by September. And apart from the inherent problem with hyperkalemia, we will be able to give ARNI to majority of our patients. That's what I believe. Contraindications, eGFR less than 30, severe hepatic impairment, pregnancy and lactation, and bilateral renal artery stenosis. These are absolute contraindications. Drug interactions, ACE inhibitors, aliskiren not available in this country, but two most important drugs we remember, NSAID and lithiums, contraindicated. What percentage of patients will have contraindications is all open to you later on. But in my opinion, in my clinical practice, around 10 to 12% patients have absolute contraindications for discontinuation of ARNI is a bad news. Mortality steeply goes up. So promote your patient, educate your patient. We all should encourage our patient and persuade him to continue ARNI therapy. Remember, as many as 10% with HFrEF improve their EF. As many as 30% with mid-range improve EF with foundational therapy. But that is no reason to stop ARNI. The guidelines clearly say all foundational therapies must be continued, in particular ARNI, even when ejection fraction improves. So that is my final slide, pearls of consensus. ARNI, molecule of the century, and is indispensable and superior to ACE inhibitor in reducing death, heart failure death, hospitalizations, and sudden cardiac death. ARNI also improves ejection fraction in HFrEF and reverses adverse LV remodeling and improves quality of life in HFpEF. ARNI should be initiated in all patients with heart failure, de novo, acute decompensated, ACE naive, or those who are on ACE. ARNI should be given for at least 3 to 6 months before considering a device. And ARNI should be used in HFpEF to reduce hospitalizations and quality of life. I thank you once again.